brings us to our final topic, which is cost, the ever-present cost. And the way I always think about a cost is really focusing on really getting the right care for our patients, right? And minimizing or significantly reducing the lower value care. As you can see from the slide, overall cost savings for our value-based practices compared to traditional Medicare is significantly improved, 20% over original Medicare. Value-based primary care physicians have focused for years on putting the infrastructure in place to drive efficiencies, to reduce waste, to get our patients who have chronic conditions to the right care at the right time. And physicians don't always like to talk about cost, which is one of the reasons I always think about it as how do you actually improve efficiency and reduce waste. But I would really be interested in hearing from you all about how much costs and potential earnings are discussed within your clinics with your physicians, and how much does that motivate your physicians? So maybe Dr. Bhansali, if I could start with you to start the conversation here.
Sure thing. So we are a for-profit PE-backed organization. As such, profitability is a priority. But we've delivered some of the best outcomes in the country in terms of utilization, total cost of care, et cetera. And so not only are we taking MA risk, but we've decided to move forward with ACO REACH global cap model, and will therefore double our full risk lives. We decided to move forward with this because we know we can deliver value. Our goal is to shift costs from the acute to the chronic side of management, improve outcomes, and save patients and the healthcare system monies, and simultaneously be profitable. I mean, this is the foundation of value-based care, and we're delivering on that promise. As we engage with our clinicians, how we perform in our value-based care models, there's direct translation of that into the profitability of our clinicians for compensation. And so we've tied that because as clinicians are expected to go above and beyond whatever they're doing day in and day out, focus on outcomes, focus on care coordination, et cetera. We want to ensure that as patients are happier and healthier, that they also are a part of that profit sharing.
Thank you. And Dr. Suresh, for you, healthcare is obviously a business, right? I'd love for you to talk a little bit about the role of value-based care in sustaining your organization during the pandemic and how that positioned you for success and being able to continue serving the patients that you do.
Absolutely. So the pandemic was, as we all know, not only significant challenges, but also opened up doors of opportunities, right? So our physicians, we have always included our physicians, rank and file PCPs and IPA leadership in every financial discussion and how their care impacts the dollars and the surplus sharing that comes through. So physicians are very aware of this. And during the pandemic, our physicians were, the physicians who were in a capitated model structure, fee structure, were the best served. So they felt this was a blessing in disguise when they were not able to see patients, when they were not able to have their offices open, staffing shortages, they still had a cap check coming in. So this really had a movement in some of our physicians who were fee for service to a capitated structure. So I think I was tying the pandemic to the financial modeling of the organization, right? So that's definitely COVID proved beneficial. And the other advantage during COVID was the education and opportunities surrounding telehealth. So that was one of the areas that our physicians had not utilized fully or even to a significant extent. And sharing those, the value of telehealth during the pandemic was immensely helpful for our physicians. So I think that telehealth model is here to stay, whether we like it or not, and the physicians are utilizing it. Even after with the pandemic subsiding a little bit, we are using telehealth in different forms, right? So they're using for follow-up post-discharge or even touch point meetings. So what Dr. Gonzalez mentioned, access, but also frequency. How often do you see your PCPs? Some of them mix it with like a hybrid thing in-person office meetings, office visits combined with a telehealth visit plus a phone call. So they are using a hybrid structure, which all was a result of how they operated during the pandemic. Those are some of the techniques that I think pandemic really helped our IPAs to wade through the situation, but also some of the practices that are here to stay.
Thank you. So actually, I'd like to end with, addressing maybe some of the physicians who may be watching this panel who are much, much earlier in their journey towards value-based care. So you all have experienced that journey yourselves. And we know that there's increasing encouragement, incentives for physicians to take on risk of some sort, whether it be from CMS in their models, but also in their other value-based programs, or from MA payers or commercial payers. And so, but it's a big lift to take on. There's a lot that goes into that, as we've spent time talking about today. So what I'd love for each of you to do, maybe starting with you, Dr. Feldman, is to talk about, one or two things that practices could start doing that maybe doesn't involve like having a contract with the payer around taking on risk, but that could start to prepare them for the type of culture and environment and things that they would need to ultimately be able to enter into value-based arrangements. What advice would you give to practices who are much, much earlier on in their progression towards value-based care, just starting to think about it?
I think there are two early processes that can be started. The first is a cultural shift towards one of understanding that the reduction of total cost of care is beneficial to the organization, right? And so that's a bit of a challenge for a fee-for-service company where every encounter is sort of viewed on its own merit without the sort of long-term goal of total reduction of care throughout the arc, either on the fiscal year or longer than that. The second is you have to invest in the proper EMR optimization. Just because you have an EMR doesn't mean it's going to deliver either the data or the tools needed to appropriately manage population health. It needs to be customized and fine-tuned. And the key to successfully optimizing your EMR is having physician engagement. What we've seen across organizations is that when the IT service does the EMR build and then presents it, it is far from optimized. The key is to have busy, successful clinicians engage in the process so that it is user-friendly, it's clinically meaningful, it's pertinent, and it isn't cumbersome. And I think those are the two early steps that can be done without significant capital expenditure. You don't need to build a whole population health team. You don't need to have a war room with analysts, but beginning to understand that we're all responsible for bending the cost curve and then providing some of the electronic tools to at least appropriately demonstrate quality, capture data, and interface with the payer.
Thank you. Dr. Suresh, what would you say?
I will go back to my slogan, education and support. So physicians who are late to join the value-based care model are realizing that they need to shift their focus now. So education from IPAs, from the leadership, from peer group sharing has definitely moved that needle for those physicians who are slow to adopt. And the second thing is CMS moving its approach from a volume-based care to value-based care has really sent a message, a strong message to some of these providers in their offices. And they're also seeing similar adoption from commercial payers, as well as their participation in ACO and now the ACO REACH. So all of this, the common theme across all of these movements in different groups of payers is volume to value. So I think our education has definitely gone a strong way and a long way to moving some of the practices from volume to value. And we see this when our IPAs are recruiting new physicians. The new physicians want to stay independent. Previously, there was a big movement, even now, from physicians who are just graduating from practices wanting to be just employed by somebody. However, with this shift in volume to value and the physicians realizing that this is a very viable way of practice, they are recruiting new physicians into their practices or even into their IPAs that want to stay independent and adopt the value-based care model. So I think the drive is moving slowly, but definitely for surely it's there. And support. I cannot emphasize enough on support. When the physician practices understand that there is support in ways that I listed previously in terms of either an embedded care coordinator or an embedded personnel in their office, providing that population health platform, and also providing timely and accurate data, moves their practice in a positive way that really helps them consider shifting from volume to value.
Excellent. Thank you. Dr. Bhansali, you get the last word.
So across Dooley, we care for about 2.5 million lives every year. And Dooley is at its core from its inception has been primarily a fee-for-service model engine. That's its fabric. And so the last year, what I've spent a large portion of my time doing is changing hearts, the value proposition across the entire organization, from operational leaders to clinical leaders to the front staff, and especially with our PCPs. And I think that true proposition of value, saying this is better for patients and better for us, and then helping understand or define how that cost shift works, why it's better, et cetera, that has been my number one strategy in engaging our organization, especially the clinical workforce, to move towards value. And once those hearts are changed, then providing tools is the next piece. But until those hearts are changed, doesn't matter what tools, doesn't even matter what compensation, people just aren't going to deeply do that work. Because this work is really deep work, right? It's rolling up your sleeves and getting the job done, whatever it takes to take care of people. And with the fee-for-service model, there just isn't, with the productivity compensation model, there just isn't enough time. So number one is that culture shift. Number two is aligning compensation to those outcomes. Because culture shift by itself with a misaligned incentive plan won't work, because then there'll be a constant discrepancy and dissonance as people are working on this. So that's the second thing. And then the third thing is figure out how to reduce hospitalizations. That is, if you do that, just that, if you don't focus on anything else and you just figure out how to reduce hospitalizations, that's going to go such a long way in making people better off and really reducing the total cost of care. So those are the three initial steps, I would say, that an organization should figure out how to do or take: changing hearts, aligning incentives on those outcomes, and then focusing on part A, specifically hospitalizations, to be successful very early on in their value-based care journey.
Well, all extremely wise words. As I think you all know, Humana is relentlessly focused on driving value-based care, getting more and more of our physicians and other clinicians into value-based arrangements. And our report this year demonstrates that that success is continuing. And I just want to thank all of you for being incredible partners with Humana. We honestly couldn't do this work without physicians like yourselves. And we genuinely appreciate the partnership. And I very much enjoyed this hour speaking with all of you. Thank you so much. Thanks to our audience. And I hope you all have a terrific day.